this window is opening from here. You can jump behind, right? This window is called auditus to antrum. What is it called? Auditus to antrum, mastoid antrum, right? There is a window here. Now, if I make middle here a simple diagram, this was canal for tensor, this is anterior side. This is canal for tensor, and what was this? Eustachian tube. This is the lateral side, this is posterior side. And this is the roof, tegment tympani. This is the roof. I made a section straight from here, right? So this is the roof, this is anterior side, this is posterior side. Here is, what is this? Your window. What is that window? Auditus to antrum. From here, this posteriorly communicate with an area which is called mastoid antrum. What is this? Mastoid antrum. This, and inside the mastoid antrum, this is very important. At birth, it is almost fully developed. And here I would love to mention ossicular bones. Malleus, incus, and stapes are the only bone in the body which at birth are fully developed. When baby is born, it cannot run. Bones need to be developed properly. But baby can hear, isn't it? So anyway, we should be always thankful to the babies. They are not born adult. Okay, let's come back. So men don't understand this, but women do. Now what I'm saying, that auditus to antrum opens posteriorly into mastoid antrum, which is about 1 centimeter area full of air. This is also well developed at birth. But after birth, from here, what are these? Mastoid air cells in variable number and variable size. Mastoid air cell starts sprouting out or growing out of the mastoid antrum, and this is a network of intercommunicating network of air spaces of variable number and variable size of the air pockets. These are called mastoid what? Air cells. So when we are talking about mastoid system, we have to talk about auditus, antrum, and air cells. Is that right? Now, will you understand now what is this? This is opening into antrum. This is one feature in the posterior wall. Second, under it just, what is this going down? Facial canal. Now another thing which I want to mention, that anterior to this, what is this? Facial canal. Now I'm going to make a section here. Posterior wall. This is posterior wall. Here there is, okay, here there is medial wall. Okay. Now I've done here that I made a section here, right? If I make a section here in the posterior wall, this is the facial, within the posterior wall, what is this going down? Facial nerve. And of course, this is the canal. What is this? Canal. Actually, just interior to it, there is a pyramidal eminence, bony eminence, right? This eminence should be here. Pyramidal eminence, right? This pyramidal eminence, it's a bony, the conical bony area which is projecting from posterior side forward. It is almost anterior to the facial canal going downward. Now, what is the importance of this? Within this bony, conical bony, it is hollow from inside. It is hollow from, you can say it is like this. It is empty from inside, and behind it, which structure is going down? Facial nerve. This is a facial nerve which is going down. This conical canal, inside it, it has a muscle, right? And this muscle is called stapedius. What is the name of this muscle? Stapedius. And its tendon come out of its apex, right? So within this, there is a muscle, and this muscle is called what? Stapedius. And tendon is coming out. This is stapedius muscle. And when facial nerve is going down, it gives a branch here. And this branch goes and supplies the, which muscle? Stapedius muscle. So we simply call it nerve to stapedius. Thank God we didn't put a funny name. It's just called nerve to stapedius. So how many branches within the Petrous part of temporal bone facial nerve has given up to now? Number 1, greater petrosal. Number 2, it gives, what is this? Nerve to stapedius. Nerve to stapedius, right? So we are having lateral semicircular canal, we are having auditus, we are having, what is this? Facial canal. Now this tendon of stapedius, when it come out, what it is doing? What was this bone? Stapes. Okay. So this tendon of the stapedius will go and attach with what? Stapes. Hold the neck of stapes. It's the neck of the stapes. Stapedius muscle holds the neck of the stapes. Now what is the purpose of this? Actually, when there is loud sound, stapedius muscle reflexly contract, and when it contract, it will tilt, what is this? Foot plate of stapes, and its movement will be reduced, restricted. What is the function of stapedius? Stapedius muscle takes origin from a pyramidal or conical eminence, bony eminence. It is hollowed out eminence. Within it, muscle resides and takes origin from the wall of this eminence, and tendons comes out and it holds the foot plate of stapes. And when it holds, it pulls the foot plate of stapes little backward, and stapes become more angulated, and then it cannot move so well. So its movement is restricted. The advantage of this is when there is loud sound, if stapedius muscle contract, it will reduce the ossicular chain movement, prevent the inner ear from excessive stimulation and damage to its delicate hair cells. Right? So it's a protective reflex, right, with the loud sound. Even this muscle contract when you are going to speak, because you are not supposed to hear too much for yourself, you are supposed to talk to others. So when you start speaking, especially loudly, your own stapedius on both sides contract and reduce the ossicular movement, so that your sound is not very annoying, at least not for yourself. Okay? Right? So this is the function of stapes. Stapedius, yes, very good. Then in the posterior wall, there is another important thing. Let me explain. Okay, let's suppose this was the, I will draw the posterior wall in a section here. Facial nerve was moving within posterior wall downward. Is that right? Facial nerve was moving within the posterior wall and downward. Right? You remember from where it came. It came here in the medial wall. What was this? Geniculate ganglion. Then it moved like this, and then from here it went down. When it was going down, eventually it will emerge at stylomastoid foramen. Yes, it will emerge from the stylomastoid foramen, and it will give branch, posterior auricular branch, and branch for the, posterior auricular supplies styloid and posterior belly of digastric. Another branch which supplies the fronto-occipitalis muscles, occipitalis part, and also some auricular muscles, extrinsic auricular muscles, and then its terminal branches move forward on the face. This is temporal, zygomatic, buccal, marginal mandibular, cervical. Everyone knows that. From here it will come out, and then it will have, what is this branch? Temporal. What is this? Zygomatic and cervical. Right? So we are not going to talk about them right now. What I really wanted to tell, from here there was one branch going on, and what was that? Yes, greater petrosal. Another branch we made it from here. What it was going to what? Stapedius. Yes, nerve to stapedius. Then before it exits from, what is this? Stylomastoid foramen, as it is going down, it gives one more branch. It gives one more branch which turns upward. It turns upward. Now this is very important to understand. When facial nerve is going down about 6 millimeter above the stylomastoid foramen, it gives one more branch. This branch is also intrapetrous. This is also in the petrous part of temporal bone. This is also in petrous part of temporal bone. This is also given off in the petrous part of temporal bone. This branch moves upward and eventually through a hole it enters into middle ear cavity. Where it has entered? Middle ear cavity. And this canaliculus is called posterior canaliculus. Right? And then it traverses the middle ear cavity. It traverses the middle ear cavity and eventually from a hole anteriorly it goes out. This nerve is very important because in middle ear infections or middle ear cholesteatoma or middle ear surgeries, sometimes this is damaged. This branch is called, this look like when previously doctors used to throw the light into what? External auditory meatus and look at the tympanic membrane. If light is too strong, not only you look at what is this? Yeah, lateral process, cone of light and handle of malleus, anterior malleolar fold, posterior malleolar fold. They could see this nerve crossing here. So they felt there is a cord in the tympanic membrane. So they named it chorda tympani. What is the name of this nerve? Chorda tympani. Right? This is a branch of facial nerve. So actually there should be a hole here. What is this? A hole here. And when facial nerve has gone down, right, it has given a branch which emerged from here. What is this? Chorda tympani. Am I clear to everyone? So this is posterior canaliculus for the chorda tympani. It is truly speaking at the angle of posterior wall and lateral wall. Exactly at this angle. You get it? So there's no need to know this detail. Only you should know that chorda tympani enters in the tympanic cavity from the posterior wall. Am I clear to everyone? Now where it goes and what it happens, that will be done in next lecture, right? What are the fibers and whatever. Now another thing. In the posterior wall there's a little depression here. There's a little depression here, right? What is the purpose of this depression? Actually, you remember there were 3 ossicles. Let me draw another diagram for you. This is chorda tympani, right? It is emerging out of it. Now, to illustrate this, yes. What is this? Malleus, and behind it there was incus. And this is a long process of incus. In the same incus has a short process. Now if you are looking from the front, it's also a very loving relationship. Now this bone incus has it's a long process, it has one short process. From here it is going backward. Short process is going backward, not upward. In my diagram it's looking upward, but actually it should be going backward. I will go back to my basic analogy. Where was my malleus? Yes, this was my malleus. This was my malleus. This was the handle of malleus, tympanic membrane here. What was this? Incus. And what was this? Long part of incus. Now this is posterior wall. What is this? Posterior wall. There is anterior wall. This is lateral wall. Now incus, head of the incus, it has long process here and short process from here going backward. And this short process is anchored with the posterior wall. Short process is anchored with the posterior wall. So this is the short process of incus. This was incus and this is here what? Long process of incus. Short process of incus fits into this depression. That is why this depression is called fossa incudus. Fossa incudus. Is that right? Fossa incudus. So what are the important features in posterior wall? Okay, let's start repeat with the medial wall. There's promontory. What is this? Oval window, round window, horizontal part of the facial canal, and semicircular canal bulge, right? Lateral semicircular canal. These are the features in cochleariformis process. These are the features in medial wall. In posterior wall, you find auditus to antrum, and with lateral semicircular canal, vertical part of facial canal, pyramidal eminence for stapes muscle, and posterior canaliculus for entry of chorda tympani into tympanic cavity, and fossa incudus to hold the posterior short process of incus. Any question up to this? Now the clinical points related with it. First is, if this lateral semicircular canal is disturbed, again vertigo, right? If pathological processes damages, what is this? Facial nerve, the same facial nerve, palsy. And if of course facial nerve is damaged before the branch to stapedius is given, then the stapedius muscle become denervated, and then stapedius muscle cannot contract and hold the stapes neck. So ossicular chain, especially when the loud sound, normally stapedius should contract and restrict the excessive movement, but restrict the excessive movement of ossicular chain. But what really happens, that if facial nerve this is damaged before it gives the branch for stapedius, then stapedius become paralyzed, and with that it cannot do its reflex function. So whenever there is little loud sound, there will be excessive movement of ossicular chain and overstimulation of inner ear, and that may produce, and you know, anything which is overstimulation, it causes unpleasant feeling. Think of any stimulation which is overstimulation. Don't think wrong, I'm talking about light. Little light is good, but if too much light in your eyes, that will produce unpleasant sensation. Little pressure or too much, it makes a difference. In the same way, it's about almost all stimuli, that when stapedius is not working and sounds which are little loud, they produce excessive movement of the ossicular chain, and that may produce excessive stimulation to inner ear, and that will increase, that will produce an uncomfort or unpleasantness associated with the loud sounds. Medically we use the term that there is increased acuity of loud sounds, right? Or we call this whole situation hyperacusis. What do we call it? Hyperacusis, right? Hyperacusis. What is hyperacusis? This is a situation in which person has increased acuity to the loud sounds, and he has unpleasant feeling associated with loud sounds due to what? Paralysis of stapedius muscle. This is one clinical point. Second important thing, damage to the chorda tympani. Here we'll discuss in later when I'll teach you the whole chorda tympani. Auditus to antrum, yes, it is very important. Through it, the middle ear infections can go back to the mastoid, and what problem they can produce. Now let's go to the mastoid structure, and of course if facial nerve is damaged going downward will be facial nerve palsy. Now I will go, okay, we have already a diagram here. If infection from the ear, they enter from here to the mastoid area, they can produce very dangerous, life-threatening pathology. Why I say mastoiditis? Yes, it can be life-threatening, because if it goes upward, again it can go to temporal lobe. Yes. And if it goes upward, tegment tympani is very thin over here to making roof. It can produce extradural abscess, or it can produce meningitis, or it can produce, yes, temporal lobe abscess. Or this process backward can damage the sigmoid sinus and produce thrombophlebitis in the sigmoid sinus or thrombosis. Or further backward, the process goes, it can produce infective process to the cerebellum or brainstem. Then, so when the pus is formed here, it becomes mandatory to surgically remove that. Right? So let me talk about surgical landmark related with here. But before I go for that, again, we have talked about auditus, we have talked about antrum, and then air cells. Antrum is present in everyone. Air cells, may be absent in 20% of adult population. Everyone does not have the same luck. Some people don't develop it, right? So now we come to some, you can say, landmark related with this area. It is external, okay, it's external acoustic meatus, right? Now I'm talking about surface landmark here. This is internal acoustic meatus. If you remove the ear, and here is a ridge, this is anterior side, right? External acoustic meatus, there is a bony ridge which goes backward. This bony ridge is called supramastoid crest. There is a mastoid process here. What is this? Mastoid process. This is called supramastoid crest. Now, this is external acoustic meatus. Which wall? This wall. Posterior wall. And what is this? Supramastoid crest on the surface. Now I'm talking about surface anatomy. That here is supramastoid crest. Here is posterior edge of external acoustic meatus. And if you draw a tangent from here, from the top, this is supramastoid triangle. This area, this has little importance, let me tell you. So what is this? Posterior margin of external acoustic meatus here. And what is this? Supramastoid crest and tangent drawn along this external acoustic meatus moving upward and meeting the supramastoid. Now, this is some important thing. This is called, what is this area called? Mastoid triangle. Yes, please? Yeah, this is some another name, McQueen's, but that's too difficult for me. So we just called it mastoid triangle. He's right. Okay. Now this triangle is extremely important. What is the importance of this triangle? Actually, if you drill here, you can directly land into mastoid system and remove the pus from here. When baby is born, this is only, you need to go only 2 or 3 millimeter deep and you will reach to the antrum. But with your age, every year, it starts getting more thickened. And in adult, sometimes you have to drill, you have to go deep 1.5 centimeter, 15 millimeter to eventually reach to the what? Mastoid? This. Is that right? So, what we can say that here to reach the mastoid antrum, you have to go through this triangle. Now this triangle is extremely important. You must recognize during the surgical procedure. Why? There are important things. Number one, if you go little up, you will enter into middle cranial fossa. You will enter into middle cranial fossa and damage very important structures. If you go behind this, you may end up into, yes, sigmoid sinus. And if you go little on this side, deep here, you know this curve, it is superimposed on facial nerve going downward. Again, I will repeat it. This is also called suprameatal triangle. What is it called? Because it is meatus. What is this? External auditory meatus. It can be called suprameatal triangle as well. The suprameatal triangle is a very, very important surface marking to be recognized. I will repeat it. It's worth repeating. Now you will tell me. It's horizontal part, right? If you go above it, you may enter into middle cranial fossa. And if this is a tangent going down, if you go behind it, posterior to it, you may have a risk to damage sigmoid sinus. And if you go a little interior to this rim, right, this corresponds, and that if you move straight with this curve deep inside, it is corresponding to this ring. Facial canal, and you may damage the facial nerve deep down. Because, why I'm saying it's important, because from here you can go to mastoid antrum to remove the pus, to remove the, to clean the mastoid antrum. Right? It's very important to clean, as I told you. If there is pus in the mastoid antrum or in the air cells, if you don't remove that, that can go above damage the temporal lobe system, or go backward and damage the sigmoid sinus, right? So it's very important to remove this. So best surgical approach is considered from laterally you go and identify first this triangle, suprameatal triangle, and then stay within the triangle because you are bounded with very important parameters on three sides. Here is middle cranial fossa, here is sigmoid sinus, and here is facial nerve. It is not facial nerve, buried deep inside is the facial nerve where it is turning downward. Right? Do you have any question up to this?
No, it is clear.
Okay, so we'll stop it here and remaining we'll discuss into next section. Thank you.